So POLAR study, it really stems from POLO study in 2019. It really set the precedent reference point for Olaparib in a maintenance setting for germline BRCA2 or 1 mutated pancreas cancer in metastatic setting. So people who have those tumor and the germline BRCA mutation would have their chemotherapy stopped, and then they will switch over to Olaparib. So yeah, POLO trial really set the precedent of the reference point. So for objective response rate was 20%, but progression-free survival rate at 6 months was 53%, and overall survival rate at 3-year time point was 43%. So it's quite significant, and they do have a good prognosis and maybe good predictive value for Olaparib. Our rationale was to select patients highly selective patients by genomically defined criteria. So we don't only select patients by platinum sensitivity, but also by their own mutations. So we had 3 different cohorts: patients with core A with a germline BRCA2 and 1 and PALB2 mutation, any of them, or core B being not otherwise specified non-core HRD genes. Core C without any of these mutations, but only hypersensitivity, a good sensitivity to platinum-based therapy. And then we gave them all same treatment. Giving the treatment was not an issue. It's all Olaparib and Pembrolizumab. It was well tolerated. As we reported, patients really did not have a lot of side effects other than what's known by Olaparib itself and the Pembrolizumab itself. When they were combined, it didn't have any other new side effects. In terms of efficacy, it was very encouraging. Instead of 20%, it did not really meet the primary endpoint. We had a co-primary endpoint of 6 months progression-free survival. From the hypothesis we had, highly selective patients can have immunogenic tumor, and we think that patients with a homologous recombination deficiency would be the best candidate. So adding Pembrolizumab on top of Olaparib that was already present and being used in the clinic, we're hoping to extend the survival benefit. The study was designed to achieve the co-primary endpoint of either 6 month progression-free survival or objective response rate. We set the bar very high, and although the response rate was very impressive at 35% for cohort A compared to the POLO trial, we can't really compare the phase 2 and 3 together, but since there was a reference point, I'm just mentioning that it was 20% in the POLO trial, but this POLAR trial, we're seeing a little bit bigger response, deeper response at 35%. It did not meet the primary endpoint still, because we set the bar very high, and I think we did the right thing. 6 months progression-free survival rate is still maturing. Our POLAR trial met 62% at the moment, but it still has to mature more. Overall survival rate for 3-year was 58% and still maturing. Still 13 patients are still ongoing, and the first patient who was enrolled into the trial 3 years ago is still ongoing without any issue. So I think most of us will agree that the best benefit of immunotherapy is actually seen in the overall survival, not in the response and the progression-free survival. And especially in the tumor like the pancreas, which is very stroma heavy and dense, it will be very difficult to use the surrogate for future outcome to some degree. So we're hoping to have much bigger, longer follow-up. The biggest significance of this is that immunotherapy, precision immunotherapy was feasible. We're able to select patients by their genotypes. We're able to profile their immune cells as well as a baseline and serial specimens for their genomics, immunologic profiles and at single cell level and spatial, and all that sample we will have a lot to learn from. So stay tuned, and I'm sure you'll see something very interesting out of this.